I'm Sunita. I'm based in Chelsea and Westminster, and Sarah will introduce herself. In the meantime, I'll start our share.
Do you want me to say hi now, Sunita?
Yes, please.
Hi, everybody. I'm Sarah Espenhahn. I'm the co-chair of the Chelsea and Westminster Maternity Voices Partnership, and I've been working with Sunita for, I think it's quite a few years now, isn't it? And it's just been an amazing partnership. So we're really pleased to be able to share some of our work with you today.
It's a partnership which has grown from strength to strength at a personal level, and also in trying to make a difference and touching on what Jill said. Each one of us is a leader, and it's just for us to set our mind that we can be that change. So Jill asked us to share what we have been doing. And I thought this image was actually the journey that we will come across, some ups and downs, but we will be making our progress as we go along. So I'll just very quickly, and I apologize if it'll be repetition, but again, reminding ourselves what the national scene is, what the reason why we are here, share some of our quality improvement projects that we've done together, and then a reflection of a clinician. So for those who have been in maternity and working around maternity, the Better Births report was the first design thinking project that sort of highlighted all aspects of maternity care, but also specifically picked up on the fact in the words of the chief medical officer, how postnatal services works is unfit for purpose. And also they're not only under-resourced, overlooked, but actually as a working place, it has its own challenges. The NCT survey picked up on the experiences of mothers, and the RCM work picked up at 8.5% of maternity budget in postnatal. There are a number of challenges that we are going to face and we are facing. Now, why this matters? It matters because the experience has a huge impact, not only immediate, but long-term, not only to the mother, the father, the partner, but to the family. But more importantly, nearly 70% of mothers that die because of pregnancy event die in the postnatal period. That number has not changed for our country for the last 10 years. There's also the association of poorer outcomes for women from Black and Asian community, and also the significance of more support needed when things go wrong in terms of baby outcomes. 2019 was the last time CQC had a survey, and very dishearteningly, it's again highlighted as I've shown here, in line with previous years. Results indicate poorer experience for mothers postnatally. So this was pre-COVID. What happens to moms when they go home? This survey, which is April 2021, found that actually in terms of support, that is lacking even beyond the maternity when they go back home and have their GP check. And this was made, a funded service by NHS England last year, a year ago. And still mothers are not getting the support they need. That was our story of postnatal as a country was really dire before COVID happened. And this recent publication shows that actually the COVID impact globally has been immense, and it's going to impact more and more. So it is for us here and now, and your timing of the workshop is fantastic, that as we come out of the pandemic, we need to design a service that is safe, that is accessible and equitable. From a maternity service point of view, I think we'll start right at the beginning where we started our journey, is try and make it better on the ward, but also think about it from service point of view. Postnatal ward plays a very crucial part in the efficiency, the safety of maternity unit. Because as you see, if mums and babies don't have a safe period in the ward and don't go home safely, it's going to impact services higher up. So mums who are waiting to get onto labour ward for induction of labour, or mums who want to leave labour ward to get to the postnatal ward. So if we don't get our processes right on the postnatal ward, we can impact negatively the outcomes, the experiences. And with that 8.5% of budget, we want to be as efficient as we can be. But also it is for us to hand over care to our community team members as promptly and as efficiently, so that they don't fall through the cracks. They don't become nobody's patient, you know. And all our mothers, all our babies are at risk of that, the way the system is set up. So that was our driver. That will be your driver. And there's a lot to be done. But we are in the right mindset and the right approach in taking forward. So I'm very quickly going to talk about two of our quality improvement projects. Sarah's going to talk about our last one. So I started postnatal work in 2015. And before that, I was like any other obstetrician. I had been trained to deliver babies, and that's where I needed to be. And that's where I was contributing the most. And then I realized as I joined my trust that there was a need. The trust had identified of more input obstetrically for postnatal care. So the Mum and Baby app was my first QI project in the postnatal ward of trying to give women information that is not a leaflet, that is available to them anywhere, anytime. So it started as our app for the postnatal ward in Chelsea. And I'm so pleased that as we've grown along, this has now gone, I think, to 11 or 12 LMSs and has been recognized through different organizations. But this has only been possible because of design thinking, and I'll talk about that next. So design thinking till 2016, I did not know anything about it. And you all may know, but you know how clinically they keep us in the hospital and we don't learn about the outside world unless we go looking for it. And what I found with design thinking, all the products that are made and that we love and enjoy actually have had design thinking as a concept. So you design something with the user in mind, the human being in mind, and then you try and you do your QI, but you design together. And that is what the WhoseShoes is doing, creating with no hierarchy, all of us together. And then you follow QI processes and you keep working on making it better. But it doesn't mean that that's the only focus. You have to be realistic. So you do want to bring excellence, desirability, but also technically, operationally, it is possible. And economically, you want to be efficient and effective. So our aim from then onwards has been to use design thinking in postnatal care. So we ran a co-design workshop with WhoseShoes in July 2017, right corner. Can you see Sarah there? We've been working for a year before then. And these were our mums and babies and dads who attended our session. And this was our infographic. In those days, you could meet and we all were in a big hall. We ate lots of cakes and cookies. And what was amazing was this was the summary. And I have only reached some parts of what the co-design workshop found we need to work on. But the things that I want to draw on are the two in circle, see the whole of me and joint working. That is what we decided we will focus on for the next QI project. So using the design thinking project, it took us about 12 months to really interview, survey, and so many people who were not clinical, who came, observed our wards, said, why are you doing this? Oh, that's really good. So we had fresh eyes. There's something called service safari in design thinking. So you're looking at your service, but outsiders are doing that for you. So there was a lot of steps that we followed through. And it was only possible because I just want to show you here in our acknowledgement for that piece of work, was see the diversity of people who helped us. The clinical team was like 0.01 in trying to gather this information. And that was the strength of our project. So it led to the postnatal digital suite. I get very excited when I talk about it because it recognized that our ward, the postnatal ward, is like no other ward in healthcare. We have got mum and baby. We've got to focus on the family. We have a lot of people who come, do their thing, go away. Length of stay is becoming shorter. And I don't know about your postnatal ward, but ours is manned by quite junior workforce. CQC survey in 2019 found that whilst we are trying to be very efficient and we want to make it very good, we actually, half the women nearly are complaining that after they've been told they can go home, they're waiting. So where is the efficiency in that kind of a model? So anyway, we looked at all of that through design. This was our board, you know, the white down board before 2019, and we designed this. We as a team, the co-design team, worked together to get a traffic lighted system that brings mum and baby care together. So you can see red needs doing. So each column is a task that has to be done, and each patient is a row. So more reds, the longer it is to get to home, the more green, they're ready to get home. Women can see this, we can see this. So it works digitally. It's very complex for me, but our team had said, what is it that we want? So what it achieves a traffic light system. Each staff member has their own bespoke dashboard. So the neonatal team does not need to know what the blood loss was. Obstetrician, it's important. So very bespoke digital dashboard, handover sheets, safety netting, bespoke discharge letter, and analytics. Analytics, mum and baby together, no silos. And so we were able to show efficiencies, improve outcomes, and improve our QI capability. So we're delivering on some of the NHS long-term plans and the Ockenden request. And then the safety netting that there was so that we continue to deliver safe care. We had a problem with babies' antibiotic doses getting missed. And so we had a system built in, the BTE assessment, which is the blood clot risk assessment. Hugely important because it contributes to the highest maternal mortality in the country. So we were able to bring all that in and keep a very close eye on our average length of stay on the ward because we want to be efficient, we want to be safe. And as you can see, the trend is followed. And why we thought this would work and why this worked with a co-design, because people using the service, observing our service with fresh eyes, were able to tell us where the problem lay. I've been doing this for 25 years. I hadn't thought of that, right? So we needed the strength of those who use the service to guide us. Very lucky that this got recognized nationally and internationally. So over to our latest project, to Sarah.
Thank you very much, Sunita. So I'm going to talk about a very exciting project, which is we finished the kind of development of it, and now it's ongoing, which is the Living Library, the Beyond Birth Living Library. And we identified that there are a lot of women and families who start off with the horrible term of, low risk. They start off their experience low risk, and then something happens along the way. And then by the time they get home, they are really struggling, but nothing has happened to tick any of the boxes that triggers the additional support that they might need. So there's a huge unmet need that we identified and put in for some funding to come up with some support for this. And Sunita identified the Living Library project in Sweden as a great way of providing support. And so the idea of the Living Library is that you have books who are people who have been through similar experiences, and then the readers are the people who currently need support, and they are teamed up, they're paired up with books that have similar experience so they can receive peer support. So one of the things about this is that it's about nobody externally is identifying who needs that support. It's for women, families, even perhaps grandparents to put up their hands and say, actually, I'm struggling here. I would like this support. And there's no judgment that goes along with that, because we all recognise that postnatal life can be really tough. We identified that there are a number of things that are more likely to make new parents feel the need for this support. So things like having an emergency operative birth, whether that's Ventouse or cesarean, or readmission to the hospital, either the mother or the baby, or those who have babies who require to stay in the intensive care unit, and parents who've had difficulty accessing care as well, whether that's because of language barriers or cultural differences, or any of the other things that might make it difficult for them. So those were the parents who we identified as particularly in need of support, but not able to get it from anywhere else. So we explored what was out there in addition to the Swedish model, and we identified some other peer support programs, not in this area, but doing similar sorts of things, and looked at what worked really well and what we could learn from them. And the team, it included experts by experience, and healthcare professionals, women, partners, grandparents. Sorry, I'm doing this all in the wrong order, Sunita. And we gathered their experience and their views actually we ran, I think, 2 WhoseShoes specifically for that project. There was definitely one with grandparents, and I think there was another one, and we had a couple of discussion forums as well. We did that with some dads. There were surveys for the health professionals and parents and other family members to take part. So we gathered all of those views about what the difficulties were and what would help. And then we put together this peer support program. So if you want to go back one. So you can see this is how people can get in touch with the peer support program. And initially, the model was that those who were looking for support would be offered 4 sessions once they'd been paired up with a book. And the idea was that would be face-to-face. But as we all know, COVID hit. And so we adapted and moved to virtual support sessions. And that meant actually that we could offer this support much more widely. So it was no longer limited to a very small geographical area. And the other change that came along was that we had planned that this support would be available from about 8 weeks postnatally, but we discovered that actually there was a real need earlier than that, and it was up to individual parents to say when they needed that support. So we changed that as well. For people who would like to provide that support, who would like to be books in our living library, we've set up a strong process to check that they'll be okay doing that, to give them some training and ongoing support. And we also have some resources that people who are looking for support can read, stories of lived experience that they can read if they're not sure whether they want to be paired up with somebody yet. So far our numbers have been quite small, but it's all established, but we're always looking for funding just to keep things ticking over and to be able to provide a service to more people, really. And I think, just to summarize, the aim of this is the recognition that once parents arrive home after having their babies, they can really feel like they're left to work everything out themselves. And many of you have already said this in the chat or out loud already. And even so, sometimes they're okay if you're okay if you have a strong family support or another local network of parents to call on. But even with that network, you can feel really isolated by your individual experience and worried about being judged or not wanting to be a burden on others around you. So that's where the peer support person can be really helpful, because there's no burden, there's no judgment. especially from somebody who's been through the same experience. So it's a great space to explore your experience without those pressures, with the flexibility to fit in with the new parent's life. So we just want to share that with more people, really. I'm going to hand back to you now, Sunita.
Thank you. So very quickly, I'm conscious of time. As I said, I've been doing this for a while, and I have done a number of audits, and I've done a number of QI projects where I, as a professional, thought, I know the solution. But what I have learned since then is that I don't. And what I think we all as clinicians need to recognize, that the success and the excellence that we need in postnatal care will only come when we work together, when we focus on those whom we are designing care for. Design thinking is the way forward, because this is when you see the whole of the mum, the family that we are taking through. We cannot have a medical model of care, because I run postnatal clinics and clinically they are fit, but that does not mean that they are enjoying, feel empowered and supported in that. And so the approach needs to be one that combines health and well-being. And we also need to see we play a crucial role in the life course of this mother, this family, intergenerational. So we do need to prioritize this. We need to take a new approach to it. And definitely you will make lots of contacts today. Please take everybody's email, get in touch later, because what I've realized is once we started doing this work, now I know people in our local authority, in our community, that we can work with, right? And I'm only this 0.1 dot in there, because there are people waiting to tell us how we can make it better, and we need to be listening, truly listening. We need to think about it as a system, no longer a ward, no longer my role. Actually think about the bigger picture and personalize care. We are personalizing with Ockenden for intrapartum, for antenatal. Extend that onto postnatal. Those principles apply to entire postnatal journey. But again, QI methodology, because you don't want to sort of spend time if it's not working. Do quick cycles, improve. And already touched on leadership. Each one of us is a leader. It's for us to decide we will be that leader. Take people along, work together. That's only time this will succeed. And that's me, really. Thank you very much.
Well, Sunita and Sarah, that was absolutely extraordinary. Honestly, I could listen to you all day. I'm so sorry we couldn't give you a longer slot. I want to hear all about your postnatal work with GPs, Sunita, all the fantastic webinars you've been running. Honestly, people, we have literally just touched the surface here. So have they got an offer to connect with you, Sunita?
Anybody postnatal, I'll connect anytime. And so will Sarah.
Yeah.
You get both of us together.
Of course, definitely. Because we learn so much from each other, don't we? None of us knows everything. So I always want to learn more.
And support each other, because, the journey is like that. But we are there to support each other. And that's the partnership you'll be able to create today with the people in the session and many more.
And I'd like to give a shout out to Rachel Clawley in Shrewsbury, one of the people we've met through our virtual workshops. She is an extraordinary mover and shaker, and she's now moved to a dedicated postnatal role. So I think she tweets as Rach Clawley. I'll remember to share the, or perhaps Carrie can, if you can find her, Carrie, put her in the chat. But she's asked, it's her birthday today, otherwise she'd be here. We've just got such a fantastic community, but postnatal needs to come to the top, I think. So thank you very much, Sunita. I think you've got a dash, have you? Got things to do, places to go. So thank you very much. Sarah, that was amazing. Thank you. Keep in touch, everybody. Are you staying with us, Sarah?
Thank you.
I'm afraid I've got to go as well. So sorry.
But what an advantage of these virtual sessions that people can just fly in like you've done. Thank you so much.
Thank you.
Okay, bye then.